So, good afternoon, everyone. I'm Dr. Aravinda Lochani. Today, in this video, we will discuss about the approach to a bleeding neonate and the management regarding the same. So, the hemostatic system is a tight balance between the structure and function of the platelets and also different coagulation components and also the plasma proteins, maintaining the balance between the procoagulant and anticoagulant state. So often the treating physician is faced up with a dilemma of what could be the cause for a bleeding in a newborn, even if it is a small bleed like a mucosal bleed or umbilical bleed, or it can masquerade as an internal organ bleed presenting with anemia needing blood transfusion, shock, and also severe systemic illness. So whenever the physician is faced with these challenges, it is important to always design a proper diagnostic algorithm and also a treatment plan for the timely salvage of these babies and saving the babies. So, before the advent of routine administration of vitamin K, the incidence of the hemorrhagic disease of the newborn used to be 1 to 2%. Now, after the advent of the routine vitamin K at birth, this risk has come down significantly. So, why the neonates are at susceptible to bleeding? Because of the physiological deficiencies of the coagulation factors, both in the quantitative and qualitative aspect, and also decreased functioning and aggregation of the platelets in preterm babies, particularly the expression of the thromboxane A2 and the inhibition of the same by the consumption of the maternal analgesic agents like aspirin and all, and also the exposure of mother to different drugs like anticoagulants and anti-epileptic drugs, and also the maternal illnesses like pregnancy induced hypertension also contribute significantly to the maintenance of the hemostatic balance in the baby. And the blood vessels of the babies are also immature of blood vessels, thereby inhibiting the brisk response following an injury to the vascular endothelium. The infants are also prone to the birth asphyxia, birth trauma, thereby leading to the injuries over the scalp like epiphelhematoma or subgaleal beads, and also followed by hypoxia, sepsis, prematurity. These all contribute significantly to the bleeding manifestations in the neonates. So now let us move on and see the neonatal hemostasis. So the protein levels when compared to the adult values, except for the fibrinogen factor 5 and factor 8 and 1 millibrand factor, the other procoagulant values, as you can see in this given table, are less when compared to the adult values in newborn babies. Similarly, anticoagulant values, except for alpha 2 macroglobulin, the other factors like antithrombin 3, heparin cofactor, protein C, protein S are less when compared to adult in a newborn. And the tissue plasminogen activator and plasminogen activator inhibitor are normal, but the other ones like plasminogen and alpha 2 antiplasmin are less compared to the children and adults. So these decrease in the procoagulant and anticoagulant and fibrinolytic factors places the newborn infant in a relatively prothrombotic state, but usually we don't see the bleeding manifestation in healthy term or preterm newborn babies. These plasma proteins levels gradually undergo maturation and reach the normal levels by around the first 6 months of age. So this part we should keep in mind whenever we are treating the babies. We should interpret the laboratory evaluation values according to the age appropriate levels. So we have been learning the method of the platelet aggregation and the coagulation cascade since our UG days. So whenever there is an injury to the intact vascular endothelium, the platelets in the blood vessel lumen, they tend to aggregate near the injured endothelium, and this disruption of the vascular endothelium stimulates the platelets to release the collagen and granules, nucleotides, serotonin, and enzymes. So, following further, The platelet adhesion also requires the secretion of thromboxane A2, ADP, fibrinogen, and also requires the support of 1 millibrand factor for the platelet aggregation. So here the platelet receptors like GP2B and GP3A activation is also necessary. So when compared to the term infants, the thromboxane A2 and ADP levels in the preterm neonates will be lesser, thereby leading to less robust aggregation and also the contraction of the platelet plug. So this is the normal platelet clotting physiology. Then coming to the coagulation cascade, you are all aware of the intrinsic pathway and the extrinsic pathway. So we will just see briefly the overview of the coagulation cascade. In the intrinsic pathway, the after damage to the vascular endothelium and along in the presence of collagen, kallikrein, and kininogen, the factor 12 gets activated to the factor 12A. Then subsequently in this cascade, factor 11 will be activated, then factor 9, and subsequently factor 10 will be activated to the factor 10A in the presence of the factor 8. This contributes for the hemophilia A, as we all know. In the extrinsic pathway, there are factors like factor 7 and 7A, and then factor 3A, and all they all conglomerate together to the active form of factor 10, that is factor 10A. Then the prothrombin is converted to the thrombin, and further the fibrinogen is converted to the fibrin, thereby forming the stable fibrin clot. Here you can see the involvement of the factors like factor 5 and also factor 13. So which are also contribute to the neonatal bleeding disorders. So whenever we are faced with a newborn having a bleed, whether it be the bleeding at the time of the birth, like a caphal hematoma, and subgaleal bleed, or followed postnatally by the bleeding from the umbilicus or any skin bleeds, then we should first, at the onset, we should collect the data regarding the maternal history. And we should also inquire about the family history of any bleeding disorder, and inquire specifically about any maternal illness during the pregnancy, like low maternal platelets, history of idiopathic thrombocytopenic purpura, any history of lupus erythematosus in the mother, did she have any excessive bruising, nosebleeds, did she have hypertension, preeclampsia, any seizure disorder, or any cardiovascular disease. Any intake of maternal drugs like aspirin, coumarin, anticonvulsants, phenobarbital, so rifampicin, isoniazid should also be inquired into. And we also should ask for any history of a prior infant with bleeding disorder. And we should also collect the details about the birth history. Was the delivery complicated or precipitous or unanticipated delivery also we should try to inquire. And then what all presentations we will see in the neonate. So first and foremost, we should assess if the baby is a well baby or a sick baby. That will decide us to narrow down the possibilities, and also to help us further when we compare it with the lab investigations. So if the baby was a sick baby, so was the baby on any prolonged IV antibiotic therapy or on prolonged TPN or liver disease, and whether vitamin K was given at birth or not should be inquired. And on physical examination of the baby, we should note whether there are any petechiae kind of rashes or diffuse purpura or ecchymosis. Is there any oozing from the umbilical stump or bleeding from the venipuncture site should be noted. You should also look for the cephal hematoma or subgaleal bleed or swelling over the scalp. And if it is a male baby, we can inquire about the prolonged bleed after circumcision and preterms present with IVH. So these are the common presentations for which babies come up in this hemorrhagic disorders. So next, coming to the etiology. So if the baby is a sick baby, so we should think of the underlying possibilities and try to treat the same, like whether there was any sepsis or septic shock, history of asphyxia, hypoxia, and followed by the coagulopathy, sepsis leading to the disseminated intravascular coagulation, whether there was any like history of abdominal distension, bilious aspirates, giving the doubt of NEC or renal vein thrombosis. If the baby is needing a prolonged NICU stay, was there any involving the vascular catheters? which leads to the platelet aggregation and thrombocytopenia. And babies who are on ECMO also are prone to consumption coagulopathy due to the circulation of the blood in the bypass circuit. And we can also divide the these disorders, coagulation disorders, into either congenital disorders or acquired disorders. Acquired is the conditions which we have discussed till now in a sick baby. Coming to the congenital disorders, we can think of the inherited disorders like hemophilias A and B, which are inherited as an X-linked recessive disorder. So that's why they are more predominant in the male offsprings. And autosomal dominant disorder like von Willebrand disease, which acts as a carrier of factor 8, should be kept in the mind. And fibrinogen levels, defects leading to dysfibrinogenemia, afibrinogenemia. And some inherited disorders are in an autosomal recessive fashion like factor 11, factor 7, 5, 10 to 13, and fibrinogen. So if for the if the baby is otherwise a well baby and platelet disorders like inherited disorders are suspected, we should think about the Glanzmann thrombasthenia and Bernard-Soulier syndrome. ITP, maternal health syndrome, should also be possibility should be kept in mind. Heparin-induced thrombocytopenia is a common phenomena with a baby on central lines and having the heparin infusion. And consumptive thrombocytopenia occurs in renal vein thrombosis and also in the Kasabach-Merritt syndrome. So the other bone marrow related causes are marrow failure syndromes like Fanconi's anemia and other rare conditions like congenital leukemia. Vascular causes and traumatic causes are rare, but possibilities in a baby with a bleeding risk. So coming to the sick neonate, so the factors which we have already discussed like asphyxia, acidosis, hypoxia, in addition to that hypothermia, hypoglycemia, prematurity with severe respiratory distress, hypotension, perinatal infections, congenital infections also causes the thrombocytopenia and the risk for bleeding. Bleeding can also be secondary to disseminated intravascular coagulation, peripheral platelet destruction, or liver dysfunction. Hepatosplenomegaly in any sick infant points towards the diagnosis of congenital or acquired infections, leukemias, and erythroblastosis fetalis. And some congenital syndromes like trisomies, radial aplasia, thrombocytopenia, Fanconi's pancytopenia, Chediak-Higashi, and Viscott-Aldrich syndrome are also possible. So if the baby appears well and having a bleeding manifestation with no other noted anomalies, then inherited conditions like hemophilias, ITP, maternal drug injection, and vitamin K deficiency, bone marrow infiltrative disorders, localized vascular lesions, factor 13 deficiency should be kept in mind. There is also one possibility of swallowed maternal blood in a baby who is a newborn after feeding if the baby is vomiting or red colored milk, or if the baby is passing blood in the blood colored meconium. If the baby is otherwise well, then the possibility of swallowed maternal blood should be kept in mind, which is diagnosed with the help of a test called APT test, in which the baby's gastric aspirate is centrifuged and 4 ml of the supernatant is taken, and the 4 ml is mixed with 1 ml of sodium hydroxide, and if only the maternal RBCs are present, they undergo lysis, whereas if the fetal RBCs are present, the RBCs will retain the shape and they appear as a pink. So this test is called as APT test, which is helped to differentiate between the fetal RBCs or maternal blood injection. This is done if the baby is well and it's just having a few blood colored strain vomiting after feeding. So that is one of the common possibility. And based on the nature of the bleeding, so we can categorize it as either low platelet thrombocytopenia related bleeding or coagulation defect. So if thrombocytopenia is there, we generally tend to see small scattered petechiae or superficial ecchymosis or bruising or bleeding from the gastrointestinal tract, mucosal bleeding, or central nervous system in some severe cases of thrombocytopenia or mucosal bleeds. On the other hand, if the bleeding is a localized bleeding, like FL hematoma, intramuscular hematoma after administration of vitamin K or administering vaccines, or umbilical stump hematoma, any localized collection or bleeding, or post-circumcision related bleeding or oozing from the puncture sites points towards the coagulation defect like hemophilia and other disorders like liver disorders, and here also the vitamin K deficiency bleeding also can happen like this. So splenomegaly, if it is there, we should think of the systemic sepsis or congenital infections or erythroblastosis fetalis. Jaundice is also seen in liver diseases and infections and resolving hematomas. So these are the different factor deficiencies and the different manifestations of the same. In hemophilia A and B, it is categorized as mild if the um, values are, sorry, here it got interchanged. If the levels are 40% and moderate is around 1 to 5%. If the factor levels are less than 1%, then it is called as the severe. The manifestation will be bleeding after circumcision or blood loss and intracranial hemorrhage or extracranial hemorrhage, extensive bruising, hematomas, and bleeding after any surgery. Fibrinogen deficiency is one possibility in a bleeding infant, presents as bleeding from the umbilical stump or after circumcision or mucocutaneous bleeding. The factors of the 2, 5, 7 extrinsic pathway factors and some common pathway factors. They present with mucocutaneous bleeding, intracranial hemorrhage, prolonged bleeding from the umbilical stump or after procedures. Factor 13 deficiency presents with umbilical stump bleeding, which can be mild or may go undetected also, or bleeding after any procedure. If the baby is sick, like having liver disease or disseminated intravascular coagulation, it causes prolonged bleeding after venipuncture or heel stick, along with the jaundice and the catastrophic bleeding like pulmonary hemorrhage also. Vitamin K deficiency, early deficiency is less than 24 hours. Classical vitamin K deficiency is between um, 1 to 7 days and late deficiency is more than 2 weeks. So this can present as cephalohematoma, umbilical stump bleeding, intracranial hemorrhage, mucosal bleeding following circumcision. So more or less the manifestations are more or less similar and overlapping between the different factors and vitamin K deficiencies. So we should take the help of the lab evaluation also, and then we should try to interpret which deficiency is causing the bleeding in a particular infant. So, coming to the prime lab evaluation, first initially we will do the CBP and prothrombin time and APTT and fibrinogen if clinical suspicion is there. So some precautions that we take while evaluating this lab parameters are we should avoid the heel stick sampling because that may lead to clumping when we are squeezing and collecting the sample into the vacutainer. And also we should try to immediately mix the sample in the EDTA container so that it does not, platelets do not aggregate to the um, bottle, the vacutainer itself, and that may lead to spuriously low platelet values. Sometimes if there is an elevated hematocrit, that is the hematocrit is more than 55%, that also can lead to the prolonged diluted coagulation times because the citrate to blood ratio of around 9:1 is difficult to maintain if the hematocrit is on the higher side. And the samples which are collected from heparinized arterial or venous lines also tend to prolong the APTT. So we should try to avoid collecting this coagulation sample from the heparinized lines. So even if some blood is collected prior and after that also the sample is collected can also lead to erroneous values. So that's why the PT, INR and APTT is better to obtain from a venipuncture sample only. Elevated bilirubin and lipids also and hemolysis also interfere with the interpretation of these values, and we should always interpret these values with the age appropriate numbers. So these are the normal values of platelets in the premature infants and term infants. It is around 1.5 to 4 lakhs. And the prothrombin time is around 14 to 22 seconds in a preterm infant, and it is up to 20 seconds, 13 to 20 seconds in a term infant. And PTT levels our values are around 35 to 55 seconds in a premature baby, and 30 to 45 seconds in a term infant. So fibrinogen values are same in both, that is 150 to 300 units per liter. So whenever we are evaluating a baby, first, after ruling out the apt test for the maternal RBCs, we will see the platelet count, PT, APTT, and fibrinogen. And the peripheral smear here plays a very vital role in looking for the number, size, and granulation of the platelets, and also fragmented RBCs will be seen in disseminated intravascular coagulation, and the size large platelets or small platelets also gives a clue to the etiology. Here we are not going in detail into the thrombocytopenia aspect because that was already covered in the previous class. So the PET levels represent the extrinsic coagulation pathway, and the APTT levels represent the intrinsic coagulation pathway. Fibrinogen levels, D-dimer, and degradation products of the fibrin. D-dimer indicates the degradation products of the fibrin that forms after the clot formation, and specific factor assays when needed should be always done. So this is the tabular form of the different etiologies. So whenever we are dealing with a baby with a bleeding manifestation, we should classify the baby into a sick baby and a well baby. So then we will decide based on the platelets. Suppose if the everything is deranged in a sick baby, like the platelets are on the lower side and the PT, APTT are deranged and on the higher side, we should think of disseminated intravascular coagulation as the cause. And if only the platelets are decreased and the PT, APTT, INR are normal, then it can be related to the platelet consumption secondary to infection, NEC, renal vein thrombosis, or indwelling central lines. If the platelets are normal and only the coagulation parameters are raised, then it can happen in liver disease, and also the factor which we already discussed, that is the heparinization, the collection of the sample from the arterial line. In a sick baby, if all these parameters are normal, it can be due to altered vascular integrity secondary to extreme prematurity, hypoxia, and acidosis. Coming to the healthy baby, if only the platelets are decreased and other parameters are normal, then we should think of immune thrombocytopenia, any occult infection or thrombosis, and abnormal bone marrow function. So if both the PT and APTT are raised, this condition is seen in the hemorrhagic disease of the newborn. So if only the APTT is raised, rest other parameters are normal, then it points towards hemophilia. And if all the other factors are normal, it can be due to trauma or anatomic abnormalities or qualitative platelet abnormalities. This is another tabular form elaborating the different factors in the different conditions. Here you can see in hemophilia A and B, as well as in hemophilia C, only the APTT levels are prolonged, rest all parameters are normal. In factor 13 deficiency, all the parameters are normal. So if you encounter a baby with a umbilical bleed or any subtle bleeding manifestation, with the baby being otherwise fine, not septic or sick, and the lab parameters all being normal, then we should always think about factor 13 deficiency. Coming to the other factors like factor 2, 5, and 10, here PT, APTT both will be elevated and the other parameters will be normal. In hemorrhagic disease of the newborn, so the PT will be more elevated, more deranged than the APTT, which can be normal also in some cases, but this abnormality reverses soon after giving the vitamin K. So if we repeat the value within 6 to 12 hours also, these values tend to come to normal. Here the platelets also will be normal, fibrinogen will be normal. In DIC and liver diseases, both combined, all the parameters will be deranged, like platelets, fibrinogen, PTA, APTT, INR, everything will be deranged. In von Willebrand disease also, all the parameters can be normal. Sometimes a slight elevation of APTT can be seen. In hypofibrinogenemia and dysfibrinogenemia, in addition to the deranged PT and APTT, we will see the low fibrinogen levels, platelets being normal. So coming to the conditions like hemophilia A and B, these are inherited like in X-linked recessive manner. So this presents mostly in the male children, and so sometimes it can also be seen in heterozygous females. This possibility should be kept in mind. One third of the cases will occur in the absence of any positive family history. This possibility also should be kept in mind. So, due to the absent the hemophilia mm, factor 8 levels, so reduced thrombin formation on the surface of the activated platelets results in a thrombosis with poor structural integrity that is more susceptible to fibrinolysis, thereby leading to the bleeding manifestations. So, if the clinical suspicion of hemophilia is strongly suspected, then the repeat testing should be done at 6 months and 12 months. So, like if in the case of severe hemophilia, mostly the neonate will present at around 1 month of life. So, the treatment for the same will be the factor replacement. So, factor 8 or factor 9 replacement based on the condition. The 1 milligram factor 1 milligram factor deficiency is another entity. So in which the 1 milligram factor has a role in the platelet aggregation, and it also serves as a carrier for the factor 8. So thereby leading to the deficiency leads to the defects in the platelet adhesion and aggregation. So neonatal presentation is very rare in von Willebrand's disease. So there are different subtypes in the von Willebrand disease, like quantitative disease is categorized under types 1 and 3, and qualitative defects are classified as 2A, 2B, 2M, and 2N. Type 3 indicates the complete absence of the von Willebrand factor, so it may present in the neonate as well. So the treatment for this will be the factor replacement using an intermediate purity of factor 8 concentrate, which also contains the high molecular weight multimers of 1 millibrand factor. Coming to the vitamin K deficiency, vitamin K is an essential cofactor for the carboxylation of the factors like 2, 7, 9, and 10 in protein C and protein S. So, vitamin K1 is naturally found in the leafy vegetables, and K2 is in the found in the intestinal bacteria. Why neonates are susceptible to vitamin deficiency? Because they don't have a sufficient bacterial colonization of the colon at birth, and there will be an inadequate intake of vitamin K in solely breastfed infants, and also there is a poor transfer of vitamin K across the placenta. So these are the factors which predispose a neonate to vitamin K deficiency. And so this presents in different forms. Early deficiency occurs in 0 to 24 hours. It presents in the form of cephal hematoma or GI bleed. So here are the risk factors we should inquire are maternal anticoagulants, anticonvulsants like phenobarbital, primidone, and anti-tuberculosis agents, rifampicin, cephalosporins. So all these should be inquired into. The classical vitamin K deficiency occurs between the age of 1 to 7 days. Presence of GI, cutaneous, nasal, umbilical bleeds, and bleed following the circumcision. So we should ask about the history of vitamin K at birth, and also inquire about the exclusivity of the breastfeeding. The late vitamin K deficiency is seen between anywhere between 8 days to 6 months, can present as a severe form of intracranial bleed. This is seen in babies who are having cholestasis, fat, malabsorption, or following prolonged antibiotics. So, in vitamin K deficiency, as we have discussed, we see the prolonged PT and PTT. In the background of normal platelets. So the values return to normal levels after administration of a single dose of vitamin K. And if the diagnosis is strongly suspected, we can give one more dose of vitamin K also. So there are some proteins which are induced in the absence of vitamin K. So these are called PIPCA proteins. Normal range will be less than 0.02 nanograms per ml. They are undetected. So after giving vitamin K, if you have to check for the whether the bleeding is due to the vitamin K deficiency only, these proteins tend to have a long half-life of more than 60 hours. So we can check for their presence and thereby conclude that the bleeding occurred due to the vitamin K deficiency. So treatment is like administering a vitamin K at birth, and in cases of cholestasis, we should give 5 mg weekly, and following antibiotic therapy of more than 7 days, we should give 1 mg of vitamin K weekly. And also prior to any major surgery, we should administer the vitamin K. So the dose being for babies born with weight more than 1000 grams, 1 milligram. For babies less than 1000 milligrams, 1000 grams, the dose is 0.5 milligrams. So treatment for vitamin K deficiency is administering vitamin K weekly, particularly in the setting of the prolonged IV antibiotic therapy, prolonged TPN, and bleeding, any minimal bleeding noted. So we can administer the vitamin K and treat the underlying cause like sepsis, shock, and shock related to anemia. So we can give the PRBC and treat the baby overall clinically and treat the underlying cause as well. And in severe cases, we can give the fresh frozen plasma. Um, if the baby is a clinically ill coagulopathy with active bleeding, or if we see the PTA, PTT values more than 2 times of the reference standard. So this is around 15 ml per kg, which is given over 3 hours. And so these are the general treatment strategies of a bleeding neonate. So if the history of maternal ITP is noted and the baby's platelet should be maintained at least 1 lakh. So if a baby is undergoing a major surgery, then the platelet count of at least 1 lakh should be maintained. And in the case of any coagulopathy, concurrent coagulopathy, 50,000 should be maintained. And if the baby is a well baby, then we can transfuse if it is less than 25,000. And in the case of ITP, like if it is suspected, so we can also consider IVIG 1 gram per kg per day for 2 days subsequently. And cryoprecipitate can be considered in conditions like hypofibrinogenemia, factor VIII deficiency, von Willebrand factor deficiency, and factor 13 deficiencies, because the cryo will be rich in these products. And according to the NNF-CPG, the prophylactic plasma transfusion is contraindicated in babies who are undergoing therapeutic hypothermia or having the deranged coagulation, unless it is associated with active bleeding or more than 2 times the reference standard. So FFP is planned only for deranged coagulation and also planned for surgery or prior to any invasive procedure. Cryoprecipitate is preferred for hypofibrinogenemia despite FFP transfusion. So these are some of the NNF recommended thresholds for platelet transfusions. This we have already discussed. Less than 25,000 in neonates with no bleeding, including neonates with NAIT or with no bleeding manifestations and no family history of intracranial hemorrhage. So 50,000 cutoff should be maintained in neonates with bleeding and concurrent coagulopathy before any surgery or previous history of any neonate affected with intracranial hemorrhage. So 1 lakh cutoff should be maintained in neonates with major bleeding like intracranial bleed or requiring any major surgery like a neurosurgery. So let us see some of the common scenarios which we encounter in our day-to-day practice, contributing to the diagnostic challenges. So if we see a well baby on day 3 of life, baby presents with the seizures, hypotension, and on examination was found to have like shock, and on doing the neurosonogram, baby is found to have any intraventricular hemorrhage or intracranial bleed. So then, so this is a well baby. So we always divide the baby into a well baby, previously well baby, or previously sick baby. So in a well baby, so then the further workup will be whether the platelets, uh, PT, APTT, and or normal or not. So here in this baby, we can see only the platelets are less, with the PT, APTT being normal. So then we should inquire about the maternal status, whether the maternal history of low platelets is there. Was there any history of maternal ITP, or any history of systemic lupus erythematosus is there or not? Whether the maternal thrombocytopenia is there or not, we should inquire. If the then we should diagnose that whether it is an immune thrombocytopenic purpura or a non alloimmune thrombocytopenia in the baby. So the management is like, as we discussed, the platelet transfusion according to the cutoffs and also the IVIG. So a newborn presents with vomitings on day 1 of life soon after feed. Baby is otherwise healthy, not having any signs of infection or sepsis, and the parameters, lab parameters being normal, like platelet count, PTA, PGT, INR, and maternal, no history of any maternal drug intake or any maternal risk factors like preeclampsia or PAH. So then we can do the APT test to look for the any ingested maternal blood that is leading to the same condition. Coming to the second scenario, here we are seeing an extreme preterm baby who was born following a history of abnormal Dopplers and was initially ventilated, later on extubated to CPAP, and then started on feeds after like the recommended period of nil per oral, and the feeds were gradually hiked as per the unit protocol. On day 8 of life, this baby develops abdominal distension, has apnea on non-invasive respiratory support, and has bilious aspirates. So here, what are the possibilities that we can think of? We can think of like either it could be a sepsis or it could be a NEC. And so then we get further workup done. So we mostly see here the PT, APTT being normal and the platelets being decreased in NEC. If say these are also PT, APTT are also deranged, then we should think of the severe systemic sepsis in the baby. The treatment plan would be keeping the NPO and starting the IV antibiotics. Coming to the third scenario, if we are seeing a 10 days old preterm baby who was given TPN since birth, and then subsequently, the baby had sepsis and was started on IV antibiotics. And later on, the baby, because of this prolonged TPN and failure to establish on enteral feeds, develops the cholestasis with elevated conjugated hyperbilirubinemia on LFT. And the baby also had some degree of IVH. So this is essentially a sick baby who has been given the prolonged TPN and antibiotics. So if we see the platelets of this baby, platelets were normal with the PT and APTT being elevated. Here, like the PT is considerably more deranged than the APTT. So this we discussed in the vitamin K deficiency, late onset vitamin K deficiency bleeding. We have discussed that the PT is more deranged when compared to the APTT with the platelets being normal. Here, we should remember to administer 1 mg of vitamin K every weekly, and we should also rule out the thrombosis and other problems by doing the ultrasound to look for the renal vein thrombosis and other possibilities also. So, coming to the fourth scenario, there is a 31-weeker baby who was born as an IUGR following abnormal absent end diastolic flow. The baby was started on CPAP, and the baby is found to have a thrombocytopenia on evaluation at birth. So the baby is otherwise a well baby. Baby is stable on the CPAP, and the baby has also started tolerating the feeds. Baby is otherwise normal. So with the PT-INR was done because the platelets were low. So those were also normal. Here we should inquire about the maternal history of maternal platelets and also maternal pregnancy-induced hypertension. So a well-preserved baby with no other comorbidities, with a history of maternal PAH and with a history of IUGR and thrombocytopenia, and sometimes also elevated hematocrit and relative leukopenia. We can um, just consider this as secondary to the maternal PAH in the baby, and regular follow-up of the platelets, and both the maternal platelets as well as the baby's platelets should be done. So this will gradually tend to show improvement in the subsequent 1 week of life. Similarly, the sepsis possibility should also be kept in mind, and the baby's vitals and activity should be frequently monitored. And now coming to the last scenario, here we are seeing a baby who presents on day 7 of life with umbilical bleed. So initially our categorization will be whether it is a sick baby or a well baby. So here it is a well baby. Baby is accepting feeds well with no history of antenatal maternal conditions like PIH or intake of any maternal medications. There was no history of any birth trauma or birth asphyxia or hypoxia or sepsis. The baby is essentially a well baby. Here we are seeing the platelets being normal, prothrombin time is also normal, and only the APTT is increased. So only APTT increase is seen in the conditions of factor 8 and factor 9 deficiency, as we have discussed in the previous slide. So hemophilia C also contributes to only elevation of the APTT, rest all parameters being normal. So here we should consider the think about the hereditary clotting factor defects. So, but since the baby presents with umbilical bleed, so one dose of vitamin K can be given at admission, and then to see if these values are becoming normal or not. And then we should also simultaneously evaluate for the hereditary clotting factor defects. So this is a very useful algorithm of a bleeding newborn. So whenever we find a baby with a bleed, skin bleed or mucosal bleed or umbilical bleed, so we will be evaluating the basics like platelets, PT and APTT-INR. So if the platelets are normal, then there is only a prolonged prothrombin time. This is seen in the factor 7 deficiency. Only prolonged APTT is seen in like factor 8, factor 9, factor 11 deficiency, as we have discussed. So this should be kept in mind. And both prolonged PT and APTT are seen in fibrinogen deficiency and also 2, 5, and 10 and multiple factors deficiency. In fibrinogen deficiency, one additional manifestation is the babies tend to have the prolonged thrombin time also. So if rest all parameters it can be normal, then we should look for the thrombin time also to rule out the fibrinogen deficiency. So if everything else is normal, platelets are normal, PT, APTT is also normal, thrombin time is also normal, then factor 13 deficiency should be evaluated by sending the specific factor assays. So there are some hemostatic disorders which have an normal screen like mild von Willebrand disease, mild hemophilia A or B, mild factor 11 deficiency or factor 13 deficiency, fibrinolytic deficiency, platelet function defects, and vascular and connective tissue disorders. These should be evaluated if a baby presents with bleeding with all the other lab parameters being normal. So that is about the today's presentation. Hope it was useful and for you in the evaluation of a infant with a bleeding manifestation. So thank you once again.